Thanks everyone for being here, and I'd like to thank the Seafood Nutrition Partnership for inviting me. I'm really happy to be able to talk with you today. So earlier today, this morning, Susan Carlson presented some really compelling evidence that sufficient intakes of omega-3 fatty acids, especially DHA, whether it's from seafood, whether it's from dietary supplements, can dramatically reduce the risk and incidence of preterm and especially early preterm birth. And in addition to preventing all the human suffering associated with that, there's also the real potential to save economic costs as well. And I'll be talking about the more economic side of that equation. So what we did is we commissioned Frost & Sullivan to do a health economic analysis of preterm prevention with DHA. And we basically had them ask the question, if every pregnant woman in the United States was provided with 1,000 milligrams per day of algal DHA as a dietary supplement, what would that mean with respect to preventing preterm births, and what would that mean from a health economic standpoint? Okay, so that's the question that we asked. And before I start, I'm going to say, I'm just from a definitional standpoint, going to use the same definitions that Susan did. So a preterm birth is any baby that's born prior to 37 complete weeks of gestation. A late preterm birth is 34 to 36 weeks. An early preterm birth is less than 34 weeks of gestation. So to start, and Susan showed a slide very similar to this, but as you can see from this graph, the preterm birth rate in the United States has been increasing dramatically since 2014, where it was 9.6% of all births were preterm, less than 37 weeks. In 2022, that rate had increased to 10.38%. 2022 is the last year for which data are available. And what this means is, in hard numbers, is in 2022, more than 380,000 babies in this country were born preterm. Now, the early preterm birth rate, which I'm not showing on the slide, is held relatively constant at around 2.8%. And what that means is in 2022, of those 380,000 infants that were born preterm, over 100,000 of them were born early preterm, less than 34 weeks of gestation. And if we compare the United States with other countries, we really don't fare very well. Okay? In 2023, I think, might have been this year, but I think it was last year, there was a paper published in The Lancet that published preterm birth rates as a percentage of live births from all around the world. What I'm showing on this slide are the top 20 countries in the world by income per capita that also had their preterm birth rates published in that Lancet article. And you can see at 10% of live births in 2020, the United States is well above everybody else. The averages in Europe tend to be 5.5% to 8.5%, and the average over those top 20 countries was 7.3%. And as Susan said earlier today, she thinks we could get down to 6%. Right? So our preterm birth rate is high, and this is reflected again in the March of Dimes report card, which gives the United States a D+ for preterm birth. And as Susan pointed out, geographically, preterm birth is not equally distributed. The rates tend to be higher in the southern states, which are shown in red in this map. They tend to be lower on the West Coast and in select states in the Northeast. But overall, the preterm birth rate in the U.S., again, well above 10%, earning a D+ from the March of Dimes. The March of Dimes report also demonstrated, and the data comes from the CDC, is there are real racial and ethnic disparities in the incidence of preterm birth in the United States, with the lowest rates of preterm and early preterm birth in Asian and non-Hispanic white populations, and with the highest incidence among black mothers. And to put, again, just a comparison, black birthing people in 2022 had a 54% higher rate of preterm birth than white birthing people, and the rate of early preterm birth was more than double. Okay? So there's a real disparity here as well. And it's important to remember, I mean, the point of, the main focus of my talk is about health economics, but let's not forget that, I mean, this has a real, human impact as well. Okay, so also from the March of Dimes report, preterm birth or low birth weight is the second leading cause of infant mortality in the United States. That's shown in the graph on the left in the orange bar, with the only cause that's higher is from birth defects. Okay, another important feature of preterm, and especially preterm birth, is that it dramatically increases the risk that infant will ultimately develop any of a variety of long-term comorbidities or disabilities or conditions, however you want to call them. And the four I'm showing on the graph are cerebral palsy, autism, intellectual and developmental disabilities, and asthma. And I'm showing these four because the costs associated with these four were captured in Frost and Sullivan's report. Okay, so if we look at cerebral palsy, which admittedly is the most dramatic here, but if you set the risk of a full-term infant's risk of developing cerebral palsy to 1, a late preterm infant is almost 3 times more likely to develop cerebral palsy, and an early preterm infant is 15 times as likely to develop cerebral palsy. And all of these, and there are other conditions as well, but these are the four that Frost and Sullivan focused on. All of these, again, in addition to the human challenges of it, there's health economic costs, increased hospitalizations, medications, reduced productivity during the lifetime. So from a health economic standpoint, these are very important conditions as well, and really affect early preterms. So let's go then to the report itself. I have here the title page, and before I forget, because I've already forgotten, I would like to thank Chris Shanahan at Frost and Sullivan, his name's on the report, for working very diligently in doing this assessment and writing this report. So again, this report came out in April of last year. I'm providing the link. You can be downloaded at everydaycounts.com, and there's a QR code there as well. And just to reiterate, the question we had them ask was, again, if every woman who's pregnant got that 1,000 milligrams per day of alkyl DHA, what would that do to the number of preterm births? What would that do to the economics? So what are their assumptions? A complete data set of birth rates and preterm birth rates was available through the year 2021 when they started this project. You may remember from the graph, or you may not, but 2021 was the highest year of preterm birth rate in all the years, since 2007 at least. So they decided to be a little more conservative when they're projecting out over time. They said, let's not start with 10.5%, that might be anomalous. Let's start with 10.1%, which was the average between 2016 and 2021. They assumed a baseline early preterm birth rate of 2.76%, and they assumed that the overall birth rate in the United States would continue to decline as it had in the previous decade, right? And so as the total number of births go down, the total number of preterm births would also be expected to go down as well, right? So these are to be conservative here in their estimates. From an efficacy of DHA supplementation standpoint, recall that Susan showed the conclusion of the Cochrane review, which was that adequate intakes could reduce preterm birth and early preterm birth by 11% and 42% respectively. Frost and Sullivan went with a slightly more conservative approach based on a separate meta-analysis, where they were assuming a 12% and 35% reduction in preterm and early preterm birth. And then again, 1,000 milligrams per day of alkyl DHA. Why did we choose that? A couple reasons. First of all, the clinical practice guideline that Susan talked about in her talk was not available yet. And so we decided to go with sort of that high level of DHA supplementation that she used in the ADORE study that she showed data about earlier in her talk. So in that study, she looked at 1,000 milligrams of alkyl DHA that was provided by DSM-Firmenich for that clinical trial. So what Frost did is they broke out the costs of preterm birth as what they define as direct costs and indirect costs. And direct costs, simply put, are basically the first 6 months of medical costs after the baby is born. So that's really driven by hospitalization and particularly costs associated with being in the NICU, the neonatal intensive care unit. So what they did is they calculated the excess medical costs, and that means the costs above what would be borne by a term infant. Okay, so we're only looking at the delta, the increase in costs. So they consulted the health economic literature around how much does the NICU cost, and I don't have a pointer, but you can see on the graph on the left, gestational age goes down as you go down on the y-axis, and not surprisingly, the cost goes up, right? They took into account the fact that about half of the babies born in the United States are born under Medicaid. Medicaid pays out less than private insurance, and they adjusted all this for inflation. And so in 2021, they estimated that the excess direct or hospitalization cost for a late preterm infant was about $20,000, and for an early preterm infant was about $149,000. They also looked at what they call the indirect costs, and these are the lifetime costs associated with the increased risk of a person developing cerebral palsy, autism, asthma, or an intellectual and developmental disability. They reviewed the health economic literature, again with costs related to these health challenges. They looked at medical costs such as physician visits, medications, hospital stays, non-medical costs like special education costs, and productivity losses, both productivity losses of the individual who had potentially developed one of these health challenges, and the lost productivity of a parent who is taking care of such an individual. And so after all these inputs are taken into account, what they determined was that overall, on average, 2/3 of the cost of preterm and early preterm birth are related to those first 6 months of hospital care. About 19% are related to productivity losses, and about 14% are related to those lifetime disability management costs. If you compare a late preterm versus an early preterm, you can see that the early preterms, not surprisingly, on average, there's a much greater cost associated with that because they're developing comorbidities in the hospital, like sepsis, potentially, and many others, and they're more likely to develop those lifelong disabilities as well. So for a late preterm, the average cost above the cost of a term infant was $44,000, and for an early preterm, over $220,000 on average. So then what you do, you multiply that $44,000 by the number of late preterms and the $220,000 by the number of early preterms, and they estimated that in 2021, the total cost of preterm birth was $34.5 billion. Okay? $23 billion of which was related to early preterm birth. What about DHA, right? If we assume that DHA reduces the incidence of preterm birth by 12%, including a reduced incidence of early preterm birth by 35%, and all those mothers had access to a protective level of DHA, it's just math. How many early preterms are there in a year? Multiply that by 35%. That's how many early preterms you prevent, right? And so extrapolating forward from 2023 to 2030, they estimated on average DHA supplementation would reduce the number of early preterm babies by 32,000 per year, or between 2023 and the end of the decade, 250,000 babies. Okay. And the number of term infants, preterm infants as a whole by 40,000. And just for clarity, that 40,000 includes the 32,000. That 32,000 is a subset of the 40,000. Okay, I showed you a couple of slides ago here that the total population cost of preterm birth was $34.5 billion in 2021, and you can see that number now on the left side of the slide. If you prevent all those preterm births, multiplied by the costs of those preterm births, that turned out in 2021 would have been a healthcare cost savings of $8.32 billion. If you account for the cost of the DHA at market value in 2021, that was estimated to be about $930 million. So you subtract that from the 8.32, there was a net avoidable preterm birth cost of $7.39 billion. So in other words, if every pregnant woman had been supplied with 1,000 milligrams per day of algal DHA, it would be predicted to prevent over 40,000 preterm births, and the net savings would have been $7.4 billion in 2021. Forecasting that forward from 2023 to 2030, a little more than taking into account, yes, declining birth rates, but also taking into account inflation, they project healthcare savings of a little more than $8 billion per year after you pay for the DHA. This is just breaking this out by cost component. Again, the majority of that cost would be saved from the hospitalization, the healthcare in the first 6 months of life, with the next big chunk being savings on lost productivity, and then savings on managing those lifetime disability challenges. So, to conclude, preterm and especially early preterm birth are leading causes of infant mortality in the United States, and they dramatically increase the risk of a variety of disabilities, including cerebral palsy and the others that I've told you about. And there are others as well, but these are the four that Frost and Sullivan focused on. The U.S. preterm birth rate has increased substantially since 2014. Currently, more than 1 in 10 infants is born preterm, and of those, more than 1 in 4 are born early preterm. There is pronounced racial and ethnic disparities in the rates of preterm and early preterm birth, with increased rates in several groups relative to white parents, with the heaviest hit being black moms. Preterm birth is estimated to have cost the U.S. over $34 billion in 2021. Most of that was associated with the early preterm births. Supplementation of all those who are pregnant with effective levels of DHA is predicted to reduce the number of preterm births by over 40,000 per year, including a reduction of over 30,000 early preterm births per year. And this would translate to, in addition to the human, helping people, this would translate to a net savings per year of over $8 billion. And so with that, I'm putting on, if you would like to download the report, you're more than welcome to, or if you give me your card, I'd happy to email it to you. Thank you very much for your attention, and I would be happy to entertain questions.
Does anyone have any questions?
Just a comment to reinforce what Jim said. These are really conservative estimates because the Cochrane Review includes countries that have very low rates of preterm birth, and that's where most of the studies have been done, frankly, is in the developed world. You saw our high rate, so we would expect a much bigger reduction in preterm birth in this country.
Jim, it strikes me that your ally, or our ally in this matter, would be the health insurance companies. They'd be very pleased to hear about they could save $8 billion by using DHA for these women. So, I don't imagine you've had time to enlist them yet, but is there any thought about doing something like that?
I think that's an excellent idea. We have been so far focused on doing advocacy around this with medical groups like ACOG, with governmental groups, trying to make it so that DHA, these supplements would be more available to women. It would be wonderful if they were available using WIC money or SNAP money. I think that your idea is a very good one, and we've talked about that. I think going to like a health maintenance organization, for example, where it's entirely encapsulated, right? They have the doctors, they have the hospitals, they have the pharmacies. I think going to a group like that and showing this type of data could be very powerful. I totally agree with you, Norm.
Joe Hiblin here. This is such a compelling and outstanding story that needs to be communicated. My question is, what might be the best Washington Post reporter or CNN reporter who has a good enough background in science that we can present this to so that we can get the word out?
I love that question. I don't have the answer, but I see Sonia's raising her hand.
I can contact his award-winning producer.
Thank you. I put a lot of thought into this also because I think it's more than compelling, but we sort of ties in what do we do socially, the social responsibility to this, now that we're sitting on this data and now that this data has been developed by many researchers in this group for 40 years, right? And it's sort of equivalent to the folic acid fortification story that really transformed how women think about their pregnancy. And I work with Jim. Julia Duchatel is in the room also. So there's three of us here who have been sitting on this for a couple of years thinking. And that's that communication piece, and that's that piece that we are speaking to the various organizations, but we need others to pick it up organically and then to drive it, because it's really not it's not our story completely. It's not our story, right? It's the story of a collective group in this room. So, and like I said, a baby is being born every day, right, with this situation, and that impacts parents, etc. So,
Question in the back.
In about 2010, there was a study by Tresand et al., a Harvard economist, that had put out that because of the 10th of an IQ point loss in IQ that was supposedly associated with mothers that had the mercury high enough to indicate that they had eaten enough seafood that supposedly would put their child at risk, $800 billion per year was being lost. I'm not certainly not going to stand behind that figure, but that was their suggestion. If we just plotted linearly how many children we know are born without the benefit of seafood nutrition, 6 or 7 IQ points per, how many $1 trillion are we talking lost because we're not adequately nourishing moms during pregnancy and their offspring?
Yeah, I think that's a really good point too. And that wasn't that sort of lost IQ points per se were not captured in that assessment, but it would be really interesting to do that.
So I was just going to say one other thing, Susan. Remember when we presented this data to when Frost and Sullivan presented the data to us, and they said they had done a lot of cost analysis. They had never seen any cost analysis that was this profound. I think that says a lot about
It does.
the story.
So the graph you have with the U.S. showing higher than any other developed country.
Yes.
What do you think could be driving that high rate compared to the other countries?
Thought a lot about that. I'm sure I don't have all the answers. I mean, part of the answer is we don't eat seafood in this country, but that's certainly not, at least we don't eat enough. And that's not the whole answer. I think there's problems with access to healthcare in a lot of populations. I'm sure there's a number of answers, and I don't have them all. But I think healthcare access, discrimination, poor diets, all those types of things would contribute to that. And there's probably many other things that I'm just not aware of. But it's reversible, right? I mean, eating seafood, taking dietary supplements, this is simple, this is straightforward, it's affordable, it's effective, right? I mean, this is not a hard thing to do.
Yeah, I just want to make a comment. We're talking about seafood. We all need to eat more seafood. Seafood's safe. But for anybody in here who's concerned about dietary supplements, I just want to say in the United States, we're really good at purifying fish oil in a supplement. We also have algal for people who are vegan and vegetarian, because vegan, vegetarian pregnant women may not want to take fish oil. But I just want to allay any concern or doubt about the quality of fish oil in the United States. We're really good at it. We've been doing it a long time. There's third-party certification. All brands are pretty good, you know, and I mean, they're all purified the same. I mean, anyway, there shouldn't be any hesitation about taking PHA.
Agreed. Thank you.